Hello everyone, this is Gilbert Morgan. I work in medical oncology in Sweden. I want to welcome you to We Oncologists and ESO Presents. We are wrapping up our week of palliative care with a presentation entitled Management of End-of-Life Symptoms and Palliation in Cancer, and it will be presented by myself. I wanted to thank you very much for your support. Recently, we have reached 1,000 Facebook followers. I don't really consider us to have any followers. I think we have colleagues that invite us into their laptops and cell phones, and we learn together. So we do this for you guys. So if you have any ideas or you have a special presentation that you think would be a benefit to the rest of the group, please send us an email. We've been getting your emails and instant messages encouraging us to do what we do, so we're going to keep on going. So thank you so much to the European School of Oncology for their support, and on behalf of We Oncologists, thank you very much. Today we're going to be wrapping up palliation, and we're going to be talking about something that is very dear to me, and this is what happens at end of life, those last few weeks of the last few days of life. Many oncologists say, well, our job ends at last line treatments, which I really don't think it does. I think that's where one part of our job ends and another one begins, because there is so much that an oncologist can do within palliation. And I believe that any good oncologist is excellent at palliative care. So I really hope that you enjoy this presentation as much as I enjoyed making it. Of course, it's interactive, so if you guys have any questions, please free along to just ask away. So let's get started with our presentation. So here we are basing this presentation highly on these two guidelines, the NICE guidelines entitled Care of Dying Adults in the Last Days of Life, and from the ESMO guidelines entitled Management of Refractory Symptoms at the End of Life and the Use of Palliative Sedation. In this presentation, if the text on the slide is normal, more than likely the recommendations came from the NICE guidelines. If the text is slanted, then the recommendations are coming from the author's own clinical practice and what I have observed. And of course, if the slide actually has an ESMO logo, then it came from the ESMO guidelines. So the starting point in treating end of life is recognizing end of life. Once we recognize it, we can look at the ESMO and NICE guidelines as a resource. Both guidelines act as recommendations in recognizing when a patient is entering end of life. However, we must rely on our individual clinical judgment in order to make decisions based on prognosis. There are 5 phases in the course of cancer. This lecture will focus on the last 2 phases where sedentary palliative therapy is needed. In the case of advanced cancer, optimal palliative care can manage the symptoms of most cancers. And although physical and psychological symptoms cannot be eliminated, they can be sufficiently relieved. So what is the quick rundown once we see that a person is entering end of life? We need to check on the patient's physiological, social, and spiritual needs, summarize the clinical signs and symptoms and how to address them, go through the clinical history and all diagnoses previously made, talk to the patient and family,
as there are a lot of patients that already have very established views of what they want to do at end of life and what they do not. When it comes down to the patient's family, from the beginning, give them the place. Remember that very few of them have ever had experience in healthcare, and for many of them, this is the first time around death. They are tired and they are suffering. We need to be there for them. By taking care of the patient's family, we take care of the patient. If the patient sees that the family is feeling bad, they will feel bad themselves. So keep the family always in the loop. They are an extra set of eyes, and they can definitely help us. They can let us know when the patient's feeling discomfort so we can come in earlier with medicine. Just like we take care of the patient, we must also take care of the family. It is important to prepare the patient and their family for death. And this is a multi-step process that is aided with good communication. The patient should always be given plenty of opportunity to talk about his or her fears before death. There are many patients that have a fear of pain, and this is where we come in. We can come in and reassure the patient and their family that you and your team will be there every step of the way to take care of that and make sure that they don't suffer. Death happens in 2 stages. The first one is a pre-active dying, and this could last up to 3 weeks. In this stage, the person withdraws from social activities, sleeps the majority of time, and seems very fatigued. He or she will consume less food and water, and wounds will heal slower. With this comes confusion, restlessness, and swollen extremities. The second stage of death is active dying, which on average lasts about 3 days. During active dying, the 3 most common signs are moist, noisy breathing, also called the death rattle, agitation, and pain. In this stage, the body begins to exhibit signs of death or imminent death. This is where sedation and painkillers are needed to relieve the distress. So please be generous with your medications. There are also less common signs of active dying. They include mottling skin, coma, hallucination, confusion, irregular breathing, cold extremities, sweating, nausea, and a urine discoloration. We may also see that the blood pressure levels may drop 20 to 30 points below normal. This will in turn result in unresponsiveness. Constant assessment is necessary, as improvement could actually indicate a stabilizing situation. To assess the patient, use the OPQRST mnemonic to remember your examination. The onset, was it sudden or gradual? Provocative palliative, what makes it better or worse? Quality, what's it feel like? Radiation, is it staying at one place or is it traveling? Severity, irritability, rating it from 0 to 10. And timing, how long has it been there? So talk to your team. Oncology nurses and family members know the patient very well, so you can get a lot of useful information, and together you can form a decision based on the team's observations. Often during the end of life, it's not what you order that helps, it's what you don't. So don't order investigations that will not affect quality of life at the end of life, unless there is a clinical need in doing so. An example of a clinical need would be ordering a blood count when you're thinking about giving a platelet transfusion in the case of a catastrophic hemorrhage. Monitor the changes every 24 hours and update the care plan often. If you're unsure, discuss it with a colleague or a palliative care specialist. Once the patient is in a palliative state, nutrition becomes less important. However, it is a natural instinct on the part of the family to want to feed the patient. It's what they know. By feeding, they think that the patient will feel better. Take the time to discuss the little importance of food at the end of life. Explain to them that feeding during this stage could not only increase nausea, but it can worsen the patient's quality of life. In situations where the patient still can eat, stick to fruits and stay away from foods that are hard to digest. Think of this. You would not feed a newborn baby steak. The same concept goes for end of life. There is a good phrase I like to use with family members to try to get them to understand what is happening at the end of life, and that is that the person is not dying because he stopped eating, but rather he stopped eating because he's dying. Hydration is a subject that goes hand in hand with nutrition. We are taught that water is the essence of life. We can support the dying person to drink if they have a desire and they're able to do so. However, make sure that they have no difficulties in swallowing or that there is a risk for aspiration. A big help can be taking care of the mouth and lips of the dying person. This can especially help with dry mouth. Encourage loved ones to give frequent sips of water, and in the case of teeth and dentures, help with cleaning. A patient's hydration status is something that needs to be assessed daily. When the times come to make a clinical decision on assisted hydration, discuss the risks and benefits. Ask yourself if the patient has expressed a preference for or against clinical assisted hydration, or if they have any cultural, spiritual, or religious beliefs that go against an advanced decision. What is the patient's level of consciousness? Does the patient have any swallowing difficulties? Is the patient even thirsty? Is there a risk for developing pulmonary edema? Is temporary recovery possible? If you decide to proceed with clinical assisted hydration, monitor at the very least every 12 hours. Evaluate changes in the signs of dehydration. Take stock of the situation and see if the patient has benefited, or has the patient been harmed. If there is benefit, then continue with the clinically assisted hydration. However, in the case of signs of fluid overload or harm, stop the rehydration immediately. If a patient is already dependent on clinically assisted hydration, consider if it's worth to continue, reduce, or even stop completely. Talk to the patient and their family. There are both pros and cons when it comes to clinically assisted hydration, although at end of life there is more of a recommendation not to give. The positive view is that this is a non-burdensome, humane supportive intervention and could be seen as a reducing of the suffering. The pros are that some clinicians see this and even report that a small volume infusions at the end of life can improve the patient's mental status and reduce agitation. They advocate hydration to help prevent renal failure, which causes accumulation of drug metabolites, especially opioids, that can lead to confusion, myoclonus, and convulsions. However, the cons outweigh the pros. The negative use of clinically assisted hydration sees it as a superfluous impediment to inevitable death that can be withdrawn, does not give comfort to the patient, and it comes with its own share of risks. If drinking and the patient has swallowing problems, there could be a risk for aspiration. Excessive assisted hydration can cause swelling and breathing difficulties. Oftentimes, the patient will request relief from suffering and give no indication to hydration or nutrition. There is dehydration theories that the actual dehydration will speed up the dying process and increase the level of endorphins in the body. Remember that the dying body can't manage fluids. Putting fluids artificially into a body that is slowly closing down means that the kidneys will not be able to process that fluid. This may lead to peripheral or pulmonary edema and dyspnea. There are positive aspects of dehydration at the end of life. It can gradually decrease peripheral edema, relieve painful pressure around the tumors, limit pulmonary secretions and effusions. It can also increase comfort by reducing the urine output, which means that there is less of a need for a urinary catheter. It can decrease the fluid in the GI tract, minimizing vomiting and the need for a nasogastric tube. And it could dry the pharyngeal secretions, decreasing the chances for death rattle, which we will discuss later on in the presentation. There are certain non-pharmacological ways we can improve symptoms at the end of life: positioning the patient and repositioning, pillows to prop up the patient or the different extremities, the use of splints, fans for airflow, especially in the case of breathing difficulties with active dying, heating pads, ice pads, massage, and this is something that we can encourage the patient loved ones to do during those last few days, counseling, relaxation therapy, music therapy. Although we will not go through them all in detail, it is good to know that they exist, so talk to your palliative team and discuss the possibilities. When dealing with medications, we have to decide what goes in and what goes out. First, once it has been established that the patient has entered the last days of life, review all of the medications the patient is taking. Discuss the medications and their importance with the patient and their family, keeping only the essentials. Stop all previous medications that are not giving symptom relief. Pen medications should always be continued unless adverse effects. In case of an overdose, such like in opioids, reduce the doses but do not withdraw rapidly. Use the dying person's individualized care plan to decide the medications that remain. So in deciding the medication, ask yourself the following: is the medication the cause of the symptom? Is this medication benefiting the patient at all? Are there cultural or individual views that need to be considered? Is the patient taking any other medication to manage the symptoms? Are there any risks with the medicine that could affect prescribing decisions, such as in the case of cyclizine against nausea and vomiting, but this could also exacerbate heart failure? When in doubt, consult your house pharmacologist. There are certain medications that once they're in, should stay in. They should not be taken out, but they can be reduced. This is the case with opioids, benzodiazepines, and diuretics. Taking out opiates and benzos at once could actually create a situation with great anxiety, worry, and agitation for the patient. If the patient is awake and has no problem swallowing, encourage the use of oral medications. When the patient is tired, constantly sleeping, unconscious, or has trouble swallowing, considering using IV or subcutaneous administration is a good thing. However, try to avoid intramuscular administration at end of life. The closer death comes, oral administrations of medicine tend to be a problem, so this warrants a move to IV or pump administration. Constant assessment needs to be done to determine if a change in the route of administration is needed. Normally, the symptoms that need to be treated in the dying are pain, anxiety, worry, dryness of mouth, nausea, and respiratory secretions. In pain management, always start with the lowest effective dose and then titrate up as clinically indicated. Seek a specialist in palliative care for advice on symptom management if unable to give relief, and especially if undesirable side effects as sedation happen. Remember that not all people in the last days of life experience pain, so make sure you inform the patient of this. Always consider non-pharmacological management of pain first, but do not delay in pain management. There's a 3-step process in pain treatment. First, we identify the cause of the pain. We manage it promptly, and we treat reversible causes of pain such as urinary retention. Although communication with patient is key to determine pain, Use a nonverbal pain scale for people who are unable to communicate or explain their pain, such as in the case of patients with dementia or learning disabilities. When treating breathlessness, identify and treat all reversible causes such as pulmonary edema or pleural effusions. As always, consider non-pharmacological management first, and remember breathlessness does not always mean start oxygen ASAP, especially in the case of active dying. In this case, do not set an oxygen mask. Rather, try a fan blowing directly in the face of the patient. A study published in The Lancet has showed that there is no benefit in adding oxygen. Only offer oxygen in cases where there is symptomatic hypoxia. So, how to treat breathlessness? You can use opioids, benzodiazepines, or a combination of both. In some cases, giving a small amount of morphine can help with breathing difficulties. Nausea and vomiting can be possible symptoms at the end of life as the body's organs start shutting down. Before acting on treatment, ask yourself, what are the possible causes? Are there certain medicine that could be causing this? Has the patient received recent chemotherapy or radiotherapy? Could the cause be psychological? Does the patient have problems with electrolyte balance, such as in the case of hypercalcemia? Increase in intracranial pressure can also give nausea and vomiting. So does the patient have any brain tumors or metastasis? Is there a GI motility disorder, such as ileus or bowel obstruction? Things to consider before starting treatment are the likely cause, the side effects to the nausea medication. Will it give sedation? Are there any other symptoms to the medication? Balancing effects when managing other symptoms? And the compatibility and drug interactions with other medicine. So you have to consult your pharmacologist for this. When nausea is due to obstructive bowel disorders, you can try scopolamine as a first-line treatment. And if you don't improve after 24 hours, you can use something like sandostatin. In the treatment of anxiety, delirium, and agitation, remember that sometimes agitation in isolation is associated with unrelieved symptoms. An example of this could be unrelieved pain that comes from a full bladder or a full rectum. Consider a non-pharmacological management first and treat reversible causes, for example, psychological causes or certain metabolic disorders, such as in the case of renal failure and hyponatremia. Use benzodiazepines to manage anxiety or agitation at the end of life. Antipsychotic medicine can also be used to manage delirium or agitation. For this, we can use haloperidol or quetiapine. In the case that agitation and delirium persist or cause unwanted sedation, seek a palliative specialist. Respiratory secretions can be distressing, but reassure the family that although the noise is distressing, it is unlikely to cause discomfort. First, consider the non-pharmacological measures, repositioning the patient, limiting the amount of time of fluid, and improve mouth care. If this does not help, tailor the treatment to the patient's need and the circumstances that are happening. You can use atropine, Robinol, Buscopan, or scopolamine. Monitor frequently, optimally every 4 hours, but at least every 12 hours. Possible side effects are delirium, agitation, excessive sedation, especially in the cases of atropine and scopolamine. The medication itself can have side effects, which will need to be treated. These can be dry mouth, delirium, sedation, urinary retention. If these side effects continue, change or stop the medication. If the noise actually continues after 12 hours, do the same. Change or stop the medication. When one approaches end of life, it is very important to prescribe anticipatory medicines. Make sure to specify the indications, dosages, and routes of administration. Assess medications needed for possible symptoms that are likely to occur in the future, such as agitation, anxiety, breathlessness, nausea, vomiting, respiratory secretions, and pain. Also take into account any possible risk of a deteriorating situation. So we have to look into the future and be able to avoid a catastrophic situation where we have a big hemorrhage or a seizure. So we have to make sure that the right medication is in. This can be in cases where a patient has a large tumor in the airways or in the esophagus, or there is brain metastasis. I have included an example of medications that could be found as needed in the patient's file. So we can include morphine, 10 milligrams per milliliter, 4 milliliters per day continuously with a subcutaneous pump, 1 milliliter bolus dose, which will be given 20 minutes in between. Haldol, 5 milligrams per milliliter, 0.1 to 0.2 milliliters subcutaneously as needed against nausea. Midazolam, 5 milligrams per milliliter, 0.2 to 0.5 milliliters subcutaneously as needed against anxiety. Robinol, 1 to 2 milliliters subcutaneously as needed against noisy respiratory secretions. Furosemide, 2 to 4 milliliters as needed against lung edema. By having these medications ordered ahead of time, the team can save time and administer as soon as possible. Palliative sedation is the method of last resort in order to relieve severe and refractory symptoms. We do this by the administration of sedative medications in a supervised setting and in order to decrease awareness or absent awareness and to relieve the burden of suffering for the terminally ill. We treat dyspnea, agitated delirium, and convulsions. Before there is talk about palliative sedation, intermittent or mild sedation should be attempted first. We can first try to achieve conscious sedation where a patient retains the ability to respond to verbal stimulus but still has pain relief from the symptoms. Sometimes the family could have concerns that palliation could lead to an early death. However, studies have shown that no difference in overall survival between patients who receive palliation and those who do not. A study of morphine showed that there was no association between the doses of morphine and survival. So talk to the patient and to the family and reassure them that palliation is to improve the quality of life. Patients who are suffering from severe distress need urgent evaluation, preferably by an expert in palliation. Treat reversible factors that may be the cause of the deterioration, such as acute bowel obstruction, elevated intracranial pressure, or an undiagnosed pulmonary infection. Constantly reevaluate the patient's prognosis. In the case that palliative sedation is needed, review the case with a multidisciplinary team. This means a palliative care team, psychiatrists, pain specialists. In order to sedate, the right medication is needed, starting with midazolam, which is a short half-life benzodiazepine with a rapid onset of action. This is mostly used for palliative sedation. Some alternatives are propofol, phenobarbital. In sedation, for management of refractory symptoms, this is always done on an inpatient setting. Administration of selected medications initially requires dose titration in order to reach adequate pain relief. Regular around-the-clock administration of medication can be done by continuous infusion or intermittent bolus. The administration method can be intravascular, intramuscular, subcutaneous, or rectal, and in certain cases even via a stoma or a gastrostomy. However, in an end-of-life situation, try to avoid intramuscular administration. It is highly recommended that in the case of breakthrough symptoms, emergency bolus therapy is available. If mild sedation is not enough, then deeper levels of sedation may be needed, especially when death is imminent. In cases where one wishes to reestablish lucidity, doses can be titrated down. This allows the opportunity to reevaluate the patient's condition and also the preference on sedation. This can also allow family members a good time for interaction, but warn the patient and the family that lucidity may not be restored always, and the symptoms might occur that could actually bring about death. Once adequate relief is achieved, monitoring patients' parameters and role of further titration are determined by clinical situation. If the patient is imminently dying, do not perform routine monitoring of vital signs such as pulse, blood pressure, and temperature. Only observe those pertaining to comfort. So in this situation, downward titration is never recommended. As death nears, gradual deterioration in the respiration is expected, and this is not a reason to decrease sedation, so keep it the way it is. The concept of respite sedation involves sedating a patient for a predetermined interval, such as 24 hours to 48 hours, then downwardly titrating the sedative dose until consciousness reappears. This transient use of sedation is used to relieve severe symptoms such as malaise, pain, agitation, and nausea. This is done before continuing with non-sedating palliative approaches with the aim of returning the patient to their pre-treatment state of consciousness. However, certain precautions are needed. Make sure to administer the lowest effective dose of sedative which provides comfort. Routinely monitor physiological parameters. When using midazolam, flumazenil should always be readily available in the case of an overdose. Inform the patient and family of the risk that consciousness may not be completely restored. In the case of life-threatening respiratory depression, decrease the treatment dose. If it's not enough, use a benzodiazepine antagonist such as flumazenil. Here is a table that is found on the ESMO guidelines with the medications used for sedation. It is important to remember that these medications are not there to end life. They're there to provide symptom relief and to help our patient. Treatment is proportionate to the prevailing symptoms, severity, and prevailing goals of care. The success of this treatment is not death. It is important to remember that palliative sedation is not slow euthanasia. Palliative sedation can be a welcome method to assure comfort, but it can also be quite distressing to the family. So make sure that the family is allowed and encouraged to be with the patient. This is an opportunity for them to say goodbye during those last days. Give repeated reassurance that other methods were tried and were ineffective. Reassure that sedation is unlikely to shorten the patient's life. Keep them informed of what is expected. Provide supportive care. Listen to their concerns. Give attention to their grief and burden. Provide regular information and updates on the patient's condition and degree of suffering. Most importantly, inform them when death is approaching. Offer the family ample opportunity before and after death to meet with patients' care providers. We have to engage in emotionally challenging conversations with patients and their families. We also need to take into consideration that the patient had preferences. The family has preferences, and sometimes even the culture can play a big role in this. So this influences how much info the patient wants to receive, how they want to receive it, and how they make their decisions. There might be a situation where the patient chooses not to receive relevant information and cannot really give informed consent to treatment. In such cases, an assent form could be made including the following statements. The patient has been offered information about the condition and treatment options. The patient has been given all the info he or she wants to receive of his condition and options, and the patient entrusts informed decisions making to a nominated person who has been informed. In cases where there is a big risk of intolerable suffering, the physician should be prepared to talk to the patient and the family. They should review together the aims with medications, the benefits, and what really is expected with palliative sedation, and the possible risks. This discussion is really good to have when the patient's family is present, as it may bring up necessary discussion that could happen between the patient and the family. Consider the patient's general condition and the prognosis and prediction of survival. What are the aims with palliative sedation, and what are the anticipated effects? What are the potential risks, such as paradoxical agitation, inadequate relief, possible assent death, aspiration, and sedation? In getting ready for death, make sure you keep the families in the loop. Let them know that death is a natural process and that the body's organs are starting to shut down. Explain things in a simple way. Do not use medical terminology. Tell them the hands and feet will begin to be cold, and this is something that you will feel. Urine production will begin to become less and less, and it will eventually stop. Breathing becomes irregular, and often noisy respiratory secretions might appear. This does not affect the patient. It is important to inform that an IV infusion is not going to make the dying process easier. Regular mouth hygiene and keeping the lips, mouth, and skin keeping moist is an important thing at the end of life. Companionship is the best help in those last few hours before death. So make sure to tell them and encourage them that they are there. A well-informed family member is seldom afraid, and they can often contribute a lot during those last few days. And they can also form a nucleus for the family if they know exactly what's happening. So the take-home message: end-of-life care should always include gut communication, always patient-centered, and with the family involved. Palliative sedation is not euthanasia. What we do to relieve symptoms, not to speed up death. Know how to use your medications. Pain? Use morphine. In the case of delirium and agitation, midazolam and other benzodiazepines or Haldol. Sometimes, rehydration with small amounts of fluids can provide relief by reducing the effects of toxic drug metabolites. Respiratory secretions, death rattle, when saliva and fluids accumulate in the oropharynx, can be relieved. Sometimes it can't, but if in those situations, don't worry, this is something that is not hurting the patient. Nausea, treat with haloperidol. Dyspnea, you can use small doses of morphine. The management of end-of-life symptoms and palliation in cancer is an important part of cancer care. By becoming more comfortable with these discussions and these medications, we can actually facilitate the dying process for our patients and for their family, and we gain their trust. So, because they know that throughout the process, a team will be there for them with the sole purpose of ensuring that they have a death with dignity and no suffering. So, us that work in this field, whether you are an oncologist, an oncology nurse, or an assistant, we have a big role to play. So knowing what to look for, knowing how to treat, and really most importantly, knowing how to talk to our patients and their family is paramount in such situations. So I really hope that you guys have enjoyed this presentation as much as I have enjoyed making it. I have also learned a lot in the process. or at least had a very, very good refresher. And I have as a goal with this that hopefully this is something that you guys already know, but it was a good refresher. And the next time that you're faced in such kind of situation, your benefit will benefit from this. Your patient will benefit from this, and that family will benefit as well. So I thank you so much for your attention. I thank you so much for your support. I know that there's a little picture there of San Antonio. It has nothing to do with anything. It's just because I'm from San Antonio and I felt a little homesick. So I figured I would put it in there. I encourage you to keep on watching us, and I thank you for your support. And I hope that you are pleased with the next two lectures that are coming up, and one of them I believe is updates of ASCO GU, and the other one is updates on gyno-oncology. So I hope you guys enjoy it. Have a good evening, and we'll see you the next time.